Evaluation and Management of BPPV. Session will be moderated by Soumya madam. So we'll be covering some of the relevant anatomy and physiology, how exactly BPPV occurs, and we'll see how to approach your diagnosis, how to evaluate, and what are the treatment options. And we'll also talk about some special situations. So first of all, the basic anatomy of the inner ear. So as we know, the inner ear is located within the petrous part of temporal bone. We have a cochlea, the vestibule, and the semicircular canals. So just think of it as two parts, a bony labyrinth and a membranous labyrinth. A bony part which is outside and the membranous part which is inside. So it is very clear in this picture. So the outside part is a bony labyrinth, and within that we have the membranous labyrinth. For example, corresponding to the bony part of the cochlea, inside we have the cochlear duct, and inside the vestibule we have our saccule and utricle, and inside our semicircular canals we have the semicircular canal ducts. So some anatomy we should be knowing is that within this bony labyrinth we have our perilymph, and within that is what is the membranous part, and within the membranous part is where we have our endolymph. So that consideration should be there. Coming to the semicircular canals, we have three of them, and all three are at right angles to each other. And inside they have the semicircular canal ducts. And we know that they are involved in maintaining balance. So we have the utricle and saccule, which are important for linear acceleration, and the semicircular canals, which are important in rotatory motions. That means it helps in angular acceleration. Now, when we see the anatomy, one important thing is all the semicircular canals have two ends. One is both ends are connected to the vestibule, and on one end there is a swelling, or rather it is enlarged. See on this side here and here it is enlarged. That is known as the ampulla, and that is where all the hair cells reside. And the movement of the endolymph within the ampulla, as we will see later on, is how the semicircular canals get activated. On the other end, it is not enlarged, and for the anterior and posterior, it is a common ending. So for these three semicircular canals, we have three ampullas, and the other end we have two other endings also. So three canals and five endings, and three of them have the ampulla. That this part of the common crust, that is important because that is where we try to dislodge all this calcium carbonate debris and all in BPPV. So this knowing of this anatomy is important. Now this is how these semicircular canals function. So think of it as these hair cells and these cupula. Cupula is just a gelatinous substance that covers the hair cells. So this part all has the endolymph. Suppose this endolymph moves, so logically, if you think about it, the cupula as well as the hair bundle also moves. So the direction to which these hair bundle moves, that results in activation or inhibition of these semicircular canals. So how does it happen? So just think about if I turn my head to the left side, the bony part also moves to the left side. But initially, due to inertia, the fluid inside it will be remaining static. So relative to the movement of the head to the left side, the movement of the fluid will be to the opposite side. So that is the important concept here. And this movement is detected by all these hair cells and the cupula. There's something more about the anatomy. So with regard to the mid-sagittal plane, the anterior and the posterior canals are at 45 degrees to the mid-sagittal plane. And we have three canals on either side, and these semicircular canals work in pairs. So pairs meaning like in one motion, that is this left anterior and this right posterior, they seem to be in one rotational plane. So when we move our head in that plane, one of them gets activated and the other one gets inhibited. Similarly, if you see here, this horizontal canal and this horizontal canal are in a horizontal plane. So one gets activated, the other gets inhibited. Similarly, this posterior and this anterior are in one rotational plane and they get activated in pairs. So how does this happen? This is something called the push-pull mechanism. So normally in the resting state as shown in this picture, both the semicircular canals, they fire at an equal rate. Suppose we turn to one side, there is activation of one and the inhibition of the other. So the same pathology also, the same principle also applies when suppose one of these semicircular canals is diseased. So if there is a disease on this side, this gets more active. So that is why all our eye movements and all happen because of this imbalance between this. So both of them, if they fire together, we'll be looking straight. So how that happens, we'll see in the subsequent slides. So this arrangement is made in such a way that whenever there is a head tilt, one of the pairs gets activated and the other pair gets inhibited. I hope that is clear. So this is the important concept. How do these semicircular canals get activated? The horizontal canal, it gets activated with the endolymph. So as I told, these are the ampulla. One end has the ampulla, this green in this diagram. So in a horizontal canal, when the movement of the endolymph is towards the ampulla, that is when the horizontal canal gets activated. And vice versa also, when the flow is away from the ampulla, it gets inhibited. In a vertical canal, that is the posterior or anterior canal, it gets activated when the flow of the endolymph is away from the ampulla. I'll tell that with an example. Based on this movement of the endolymph, this semicircular canals gets activated or inhibited. So this movement causes activation of the vestibulo-ocular reflex, and how exactly this picture looks a bit complicated now. We'll try to dissect it out. So first we'll see the basic picture. So when we are looking to the sides, suppose we are looking at this head from the backward region, and this is how the semicircular canals are oriented. And suppose he looks to the left side. So if we just try to imagine it, if I turn this head to the left side, the bony semicircular canal also moves to the left side. But because of the inertia, the fluid moves in the opposite direction. So if we logically think in this orange one, the movement of the fluid will be like this towards the ampulla. So as I said earlier, the horizontal canal gets stimulated when the movement is towards the ampulla. So when I look to my left side, due to the movement of the endolymph towards the ampulla, this left horizontal semicircular canal gets activated. Okay. So this is the pathway that happens. Once the horizontal canal gets activated, the impulse goes, this is a vestibular nucleus, it goes to the medial vestibular nucleus. From the medial vestibular nucleus, it goes directly to the sixth nerve nucleus on the opposite side. And from the sixth nerve, it activates the lateral rectus on the same side. And this is the same pathway we learned earlier on. While the sixth gets activated via the MLF, the impulse goes to the opposite side, third nerve also. So whenever a horizontal semicircular canal gets activated on one side, the ipsilateral medial rectus and the contralateral lateral rectus gets activated, and there is eye movement to the opposite side. So that is a basic understanding. So whenever we turn to one side, due to activation of the horizontal canal on that side, the eyes get deviated to the opposite side. So that is a basic understanding of VOR. So this is what happens in a horizontal case. Eye moves right. VOR. So basically, when we look, when the head turns to the left, the eyes move towards the right. That is the basis of VOR. Now, again, consider what happens when we look down. So again, if you try to imagine when I do like this, when I'm looking down, just consider the anterior semicircular canal. So the bony part of the anterior canal goes down when I look down. But due to the inertia, the endolymph actually moves in the opposite direction. So if just looking at this picture of the anterior canal, the movement of the endolymph will be like this. So the movement is away from the ampulla. So as I said earlier, these vertical canals get stimulated when the movement of the fluid is away from the ampulla. So when I look down, because the fluid here goes like this, the movement is away from the ampulla, the anterior semicircular canal gets activated. Now, what happens when this anterior semicircular canal gets activated? So this is the another pathway from the anterior canal. Again, it goes to the median vestibular nucleus. From the median vestibular nucleus, it goes to the opposite side, third nerve nucleus complex. In the third nerve nucleus complex, it activates the inferior oblique subnucleus and the superior rectus subnucleus. So from what we know earlier, the superior rectus subnucleus, when it's stimulated on one side, it activates the contralateral superior rectus. So from this side, thus the same side inferior oblique and the opposite side superior rectus gets stimulated. So as a result, the eyes move upwards. So this is the main pathway. There are two other pathways that are described. This is mainly in cats and other feline animals. So from this anterior canal, it can go via the superior vestibular nucleus. From there, it crosses over directly to the third nerve nucleus. It can either go directly or it can go in association with the ventral tegmental tract. Again, it's not that important in humans. In what happens for us is mainly via this pathway, via the median vestibular nucleus into the third nerve complex. So when I look down, the anterior canal gets stimulated on both sides, and there is inhibition of the posterior canal. And while both the anterior gets stimulated, both the superior rectus and both the inferior obliques get activated, and we look up. So when we look down, the eyes move upwards, and that is VOR. It's activated. Rectus and bilateral. Single. Paired. It will, if bilateral are stimulated, both will get stimulated. So this is how what happens when we look down. Now suppose just imagine what happens when we look up. So when we look up, just concentrate on the posterior semicircular canal. So when I'm looking up, the bony part of the posterior semicircular canal goes downwards. And again, as a result of inertia, the movement of the ampullary fluid is away from the posterior semicircular canal. Away from the movement of the endolymph is away from the posterior semicircular canal. So as a result, this posterior semicircular canal gets activated. Now, what happens when this gets activated? Again, it goes to the vestibular nucleus, mainly the medial vestibular nucleus. From there, it goes directly to the fourth nerve nucleus on the opposite side and the third nerve subnucleus complex. The fourth nerve and nucleus, when it gets stimulated, it results in activation of the opposite side superior oblique. And from the third nerve, it innervates the inferior rectus. So when a posterior semicircular canal gets activated on one side, there is activation of the same side superior oblique and the opposite side inferior rectus. So that is how on looking up, our eyes move downwards. So when we look straight down, both the posterior canals get activated and there is activation of both inferior rectus and both superior oblique. So that is how the basic functioning of the semicircular canals is. I hope that is clear. So with that basic understanding, we go to BPPV. It is one of the most common causes of vertigo with a lifetime prevalence of around 3%. And the primary idiopathic BPPV is seen mostly in 50 to 70-year-olds. And historically speaking, it was first described back in 1921 by Barani. And our classic Ritz-Hallpike maneuver was described in 1952. So what is the etiopathogenesis? The current accepted theory is something called canalolithiasis, and it was proposed back in 93. So there are these calcium carbonate crystals which are normally present in the utricle. So as I said earlier, the movement of the hair cells is responsible for activation of the cochlear nerve. So these are normally there and it has a function to activate the hair cells. In BPP, what happens is instead of here, it gets trapped in one of these canals. So if you think about it, if there are some other substances within the semicircular canals on head movements, suppose these particles move, it can result in movement of the endolymph, and this movement of the endolymph, whether it is towards or away from the ampulla, that results in activation of the semicircular canals. So this is how the pathogenesis of BPPV happens. So coming to the causes, around up to 70% may be a primary or idiopathic BPPV, and many secondary causes have also been described. One of them is head trauma, and the mechanism is that there is a release of a lot of autogony into the endolymph, and they are notorious for having bilateral BPPV. A similar mechanism is also happening in after ear surgery when there is again release of the autogonia. Some other conditions are vestibular neuronitis and labyrinthitis, and also in Meniere's disease, which is notorious to cause posterior canal BPPV. And migraine also has been associated with BPPV, and the mechanism that they say is because of the spasm of the arteries of the inner ear. So migraine can actually coexist with BPPV. So which canal is commonly affected? The most common and invariably the most we see in clinical practice is the posterior canal affliction. Up to 95% is due to involvement of the posterior canal. A small chunk, that is 10 to 15%, is by the horizontal canal, and very rarely we can have involvement of the anterior canal also. So why is it always a posterior canal? It is because of the anatomical susceptibility. And also one more proposed theory is that as most people sleep on the right side, it makes the posterior canal more anatomically susceptible. So what are the clinical features? Our cardinal clinical feature is brief, severe episodes of true vertigo. And brief means it lasts for a few seconds, and typically what textbooks say it should last under a minute, but maybe up to 2 to 3 minutes it's acceptable. So seconds to 1 or 2 minutes, severe vertigo, and invariably associated with nausea or vomiting. And these are triggered by changes in head position. There are typical head position changes that have been described, such as lying down, sitting up or rolling up in bed, bending over, and extending the head backwards. And there is something called morning vertigo, and these attacks of vertigo are said to be more common in the morning hours. And also, while they're sleeping, the first position changes when they have this maximum vertigo. And on repeated position changes, the intensity of the episodes come down. And some other clinical clues, BPPV has an episodic nature. In posterior canal BPPV, these episodes repeat over weeks to months, whereas in horizontal canal, it occurs over days to weeks. So always, as I said, it is triggered by head movement in most cases. So if there is no relation to head movement, we should always look for a central cause. So, and the vertigo is usually very intense in a posterior canal BPPV. Maybe in a lateral and horizontal canal BPPV, it might be a bit mild, but usually severe vertigo lasting seconds to 2 to 3 minutes is the dictum in BPPV. So, also BPPV sudden in onset, but central causes present gradually, maybe except maybe an eye artery infarct, which can cause acute vertigo. It's a central cause. So clinically, how do you differentiate between a central and peripheral vertigo? So a central vertigo, maybe if it's due to a mass lesion or something, it can last for hours to days. And it has a slow compensation because the central part that's being affected. In a peripheral vertigo, as in BPP or manias, it lasts for seconds to minutes and there is quick compensation. And the peripheral is the one that is significantly associated with vomiting and significantly worsens with head movement. But these both can occur to an extent in central also. And we should always look for associated symptoms, like in many years where there is tinnitus or hearing loss or oral fullness. And then central causes based on where it is involved, we can have associated features like ataxia or cranial nerve involvement. And nystagmus also, it helps to differentiate. I'll talk about that in the next slide. So before that, what is the role of head impulse test? First of all, in this BPPV, it is not that important because we might not have a reliable result. But always in an acute severe vertigo with nystagmus, we should always look for head impulse test to see if it is a central or a peripheral. So what we tell is we tell the patient to look at our nose and we turn their head quickly to either sides. Normally, what we expect is a VOR, the mechanism which we just described. So when I turn the head to one side, there will be compensatory eye movement to the opposite side, which will be equal to how much I have pushed to the other side. So the gaze will be fixed onto the nose itself. In an abnormal response, initially the eyes will move towards the direction I changed the head, followed by catch-up saccade. So this is evident in this video. So here, when I turn the head to the right side, the gaze does not appear to change. But when I turn to the left, you can see there's a catch-up saccade. There's a catch-up saccade to make the gaze fix onto the nose. So this is a peripheral vertigo, a peripheral condition, abnormal head impulse. So there are some limitations of head impulse test. What the classical teaching is that in an acute vestibular syndrome with nystagmus, if it is normal, then it is a central lesions, but there are exceptions to either sides. In a BPTV, which we know is peripheral, they may not have an abnormal head impulse test. Also in central causes such as infarcts involving the flocculus or the vestibular nucleus or the rotatory zone of the vestibular nerve, or when there is an ICA stroke with labyrinthine involvement, all of these can have positive head impulse test also. So always when we do this, the test should be appropriate to the sitting, and always it should be done in a patient with nystagmus. Without nystagmus, the results may be misleading. And the second part is nystagmus in a peripheral vestibular dysfunction. So as I said earlier, both these semicircular canals, they fire at the same time so that we look straight. Suppose one of them is damaged, the other one fires more. So suppose, for example, if in this person the right side is damaged and the left is functioning more. So uh, the pathway which you described earlier, if this gets active, there is eyes deviation to this side. So if this is damaged, this gets more active and the eyes move to this side. So as a result, when the eyes move to this side, the catch-up saccade will be to the opposite side. So the fast component in a peripheral nystagmus will be to opposite to the side of the involvement. I'll tell that once more. This system, if it's damaged, this is more active. So this moves the eyes to the opposite side, and the catch-up saccade will be to this side, which is opposite to the side of the initial involvement. So this is how nystagmus occurs in a peripheral vestibular dysfunction. And it also obeys Alexander's law. So if the fast component is towards this side, if you look to that side, the amplitude of the nystagmus will be increased. So that is seen in this example. So we can see that the fast component is towards the left side. So on looking to the left, the amplitude is significantly increased. It is present in the neutral position also on looking to the opposite side also. So you can actually classify it based on whether it's grade 1, 2, 3. So this is grade 3 nystagmus. So again, some more points to differentiate it. If it's a pure vertical or a pure torsional nystagmus, it's almost invariably due to a central cause. In a unilateral peripheral lesion, it can be purely horizontal or horizontal rotatory or have vertical components also. This is the important part. Visual fixation can suppress the peripheral nystagmus. So even in a patient with BPPV, when we're looking for nystagmus, when we're doing a Dixolpec maneuver, we should not ask the patient to fix his gaze on something, because fixation can actually abolish this nystagmus. So again, to summarize, these are the characteristics of a peripheral nystagmus. It is unidirectional, in contrast to something like a Gacy-Bock nystagmus seen in a cerebellar lesion, which on the fast component changes on which direction we are looking. In a peripheral nystagmus, it is always unidirectional. It almost always obeys Alexander's law. There is fatigability and latency, and it is accentuated by suppression of visual fixation. And pure vertical and pure torsional nystagmus is not seen in a peripheral cause. Excited. So all these, what I told now is not actually applicable for BPPV, because in BPPV, what happens is not entirely applicable in BPPV, because what happens in BPPV is, because as I told, due to the movement of this autoconia, there is activation of a different semicircular canals. So how exactly that happens, we'll see. So in BPPV, we may not always see the nystagmus in a neutral testing. We have to do all this positional testing to see it. So can central. Semicircular. Semicircular. So how do we diagnose BPPV? So there is a diagnostic criteria. So all these four must be satisfied. So there should be recurrent attacks of a positional vertigo, which should be lasting less than a minute. And this positional nystagmus should be elicited on one of our positional maneuvers, and it should not be attributable to any other cause. So coming to the positional testing, we have our Dix-Hallpike maneuver, which is for posterior and anterior canal BPPV, and a supine roll test for horizontal canal BPPV. So we'll see all these in detail. So we know that all these has to be done in a case of BPPV, but we normally don't do all these pushing testing or Lipley's maneuver in our routine clinical practice. So actually there was a study, and they spoke to many emergency physicians and asked why they were not doing these frequently. So most people, the thing is, they told they had a negative experience with it or forgot how to perform the maneuver. So this is probably one of the reasons why we are also mostly not doing it. And only when we are aware of it, we'll be able to do it properly. And probably by the end of the seminar, all of us will be confident to do one of these maneuvers. So coming to posterior canal BPPV, it is the most common type, as I said earlier, up to 95%. And the vertigo typically occurs on vertical movements, upward or downwards. So Dix-Hallpike is used, and we see what the nystagmus is. So in a Dix-Hallpike test, what we do is we turn the head 45 degrees to the side to be tested, and the patient is made to lie supine. And the head is overextended by 20. I'll show a video in the next slide. And the head is overextended by 20 degrees, and it is held for around 30 seconds. So this Dix-Hallpike should not be done in certain conditions when there is musculoskeletal problems involving the head and neck region, or something like a vertebrobasilar insufficiency. Otherwise, it can be done rather safely. So this is how it is done. So if you are planning to check the right side, the head is turned to the right side, then we are making the patient lie supine and extended by 20 degree, and we keep for around 30 seconds to 1 minute, because in a peripheral nystagmus there will also always be a latency after which we can elicit the nystagmus. So we should wait for an adequate period of time. And one important thing is we should not tell the patient to focus on anything. So because visual suppression can prevent or diminish the peripheral nystagmus. So we should do in one side, make the patient get up and do it on the other side. And in both cases, we look for the nystagmus. So how exactly is the nystagmus? In a typical posterior canal BPPV, after a 2 to 20 second latent period, we have the nystagmus, which is an upward and torsional nystagmus, and the rotatory component is towards the affected side. And this nystagmus lasts for around 20 to 40 seconds. And there is always an element of fatigability. So when we repeatedly do the Dix-Hallpike, the nystagmus comes down. And again, as I said, visual fixation can suppress the nystagmus, so we should avoid fixation. So what exactly happens here? So just look at this picture. It is based on what I initially described. So initially, all this otoconia are present here. When we make the patient go supine, the direction of this otoconia is away from the ampulla. So the endolymph movement is away from the ampulla. And as I said earlier, these vertical canals get stimulated when the direction of flow is away from the ampulla. So here, what happens is when the patient is made to lie supine, due to this flow away from the ampulla, the posterior semicircular canal gets activated. So as we said earlier, when the posterior canal gets activated, there is activation of the ipsilateral superior oblique and the contralateral inferior rectus. So as a result, the eyes move downwards, and the opposite direction we will get the nystagmus, that is upbeating nystagmus. So this is how the pathogenesis occurs. Upbeating torsional nystagmus with the torsional component towards the affected side. So this is a video demonstrating it. So they've used a video nystagmogram to see it clearly. So initially there's no nystagmus. After a latent period, we see the typical vertical upbeating nystagmus. So this is very classical of a posterior canal BPPV. So we do the Dix-Hallpike in a patient who has a typical history of an vertigo.
You are trying to simulate the right posture.
Right posterior. So what happens if you are clinically suspecting BPPV and the Dix-Hallpike turns out to be negative? One important thing is it might still be an anterior canal, horizontal canal BPPV. So in that case, we should roll it out with the supine roll test. Also, there are some more practical issues. Suppose a patient had an episode maybe 2 weeks ago, and now he's presenting to us. Even if we do the Dix-Hallpike, it might turn out to be negative. And one more pitfall is we should not tell him to fix on anything. Make sure that he does not fix, or we can use a video nystagmogram. And one more practical aspect is, even if the clinical features are very typical, and even if the Dix-Hallpike turns out to be negative, we are still warranted to give a trial of Epley's maneuver to look for improvement. So once we have diagnosed BPPV, what is the next step? So the next step is coming slides. So coming to the physical laboratory maneuvers. So again, we look at this picture. So what happens is we have all this debris within these canals. So what we are aiming to do is make the debris come out of the canal through the common crus. We cannot make it go through these sites because these sites have the ampulla. So any movement through the ampulla will result in activation of the canals. So the aim of this maneuvers is to make sure these autoconial debris go inside via the common crus and not via the ampulla. So there are different physical laboratory maneuvers. The Epley's and Simmons maneuver for posterior canal BPPV, the barbecue roll and the Guffoni maneuver for horizontal canal BPPV, and the Jacobino maneuver for anterior canal BPPV. We'll see all that in detail. So first of all, what do we do in a posterior canal BPPV? We have two options, the Epley's and the Simmons maneuver. There are multiple studies which compared either, and both of them have almost equal efficacy. So one practical thing is, for very obese people, we can try the Epley's maneuver. It is easier to do in obese people. Whereas people who are having musculoskeletal issues in the shoulder neck region, those we can try for the Simmons maneuver. So how to do these maneuvers? So for the Epley's maneuver, the initial part is similar to our Dix-Hallpike. We turn the head 45 degrees to the affected side, then make the patient lie supine with the head downwards. Then we look for the nystagmus. The next step should be done only once the nystagmus improves. So or 30 seconds. Then I'll show a video in the next slide also. So next we rotate the patient's head 90 degrees to the opposite side. So initially it was to this side. We rotate 90 degrees to the opposite side. The next step is turn the body to that side so that the head looks directly downwards. So that is the important part. The head should look at the floor. And after that, we make the patient come back to the sitting position. I'll show the video. So suppose a patient is having a right posterior canal BPPV. So the initial head turn is to the right side, 45 degree. We make the patient lie down. Then we look for the nystagmus. And once the nystagmus has subsided, we turn the head 90 degree to the opposite side. And after 30 seconds, again, we turn the whole body to that side so that the head is directly facing downwards. And after this, we make the patient sit up. So as shown in this picture, while doing all these steps, these autoconal debris, they move from here and finally end up in the crus. So ends up in the crus and into the utricle, and that's how we treat Epley's. So one important thing is that the transition from one position to the next should be performed quickly, but not abruptly. We should not like just drop the patient like. In some people who have significant nausea or maybe bit anxious, we can pre-medicate with something, antivertiginous drugs. So there are multiple studies are showing that the success rate is improved by repeating the maneuver maybe 2 to 3 times in a single session itself. So if he's not getting adequate relief with one session, we can do two, three maneuvers on the same session itself. So there was previously a recommendation that the patient has to sit upright for 48 hours after the procedure, but current evidence suggests that it is not required. How much time is a bit varying. Some others recommend maybe up to 1 hour. Some people recommend up to 3 hours, but maybe 1 to 3 hours is all that's required. 48 hours is definitely not required. So what after performing an Epley's, we have to recheck the Dix-Hallpike to see if the patient has been cured. And if the nystagmus is still persisting, we can do the Epley's again, as I just mentioned. So that was the Epley's maneuver. Next, we move on. We can do it as early as possible, but if the patient is having significant symptoms where it might get precipitated, we can give maybe MSET, ondansetron or some drugs like that to suppress the symptoms, then do it. Because he might not tolerate all the vertigo which occurs during the procedure. We can do it as early as possible. So because these have been shown to be more effective than drugs for the management of. So that was the Eppes maneuver. Next is a Simon's maneuver. So this is comparatively easy to do. But the thing is, the first part is a bit different. The head is turned 45-degree to the normal side. Usually for all these maneuvers, we look to the affected side. Here, we look to the normal side. And after that, the patient is made to lie down in the same head position to the affected side. So in this picture, what happens is this patient is having a right-sided posterior canal involvement. So head turned to the left side, then made to lie down on the right side, then made to lie down exactly like that, again towards the left side, then make the patient sit up. So I'll show the video. So suppose again this patient is having a left posterior canal BPPV. We make the patient look to the right, make the patient lie down on the left side, wait for maybe 30 seconds to 1 minute, then repeat it on the other side, then again sit up. So that head position should not change. That's what's important here. So as shown in this picture, again, what happens is this from this posterior canal, it goes into the common crus and back into the utricle, and it elevates the symptoms. So that was about posterior canal BPPV. Next, we move to horizontal canal BPPV, which is less common around 20% of the cases. So in anterior and posterior canal BPPV, the episodes are typically occurring when there is vertical head movement. Here it is more of a horizontal head movement that triggers the symptoms. It is usually idiopathic or it can occur as a result of minor trauma. And one more important thing is when we're doing the Eppes for posterior canal repositioning, it can sometimes become a horizontal canal BPPV. So what is different about horizontal canal BPPV thing is our disc Hall pike will be usually negative. Very rarely we get a horizontal nystagmus. So we need to do a supine roll test. So that is what I told earlier. In a patient who is having a typical positional vertigo, and if the disc Hall pike is negative, we should always do this supine roll test to see we are not missing a horizontal semicircular canal involvement. And for treatment also, the Eppes maneuver is not at all useful. There are two other methods, the barbecue roll maneuver and the Guffoni maneuver. So we'll see that. So next is the supine roll test. So doing this is very easy. The patient is made to lie supine and the head is lifted 30-degree. We can use a pillow for that. And the head is quickly turned to one side followed by the other side. The nystagmus part is a bit tricky. It is called either a geotropic or an apogeotropic nystagmus. Geo means ground. So geotropic means the nystagmus is towards the ground. And apogeotropic means it is away from the ground. And it is always a horizontal nystagmus. So based on whether it is geotropic or apogeotropic, the direction changes. We'll come back to this table after seeing what the mechanism is. So there are two theories here, two mechanisms. One is called canalolithiasis, one is called cupulolithiasis. So canalolithiasis means this autoconal debris are freely floating in the horizontal canals, whereas in cupulolithiasis, they are adherent to the cupula. So these are two patients, both are having involvement of the right horizontal semicircular canal. Patient A has a canalolithiasis. So what happens when I turn his head to the right side on supine roll test? These autoconal debris, they move towards this ampulla, and this flow towards the ampulla as in a horizontal canal leads to activation of the horizontal canal, as we said earlier. So when there is activation of the horizontal canal on one side, the eyes move towards the opposite side and the compensated nystagmus will be to the same side. So here, when I turn the head to the right side, in a right horizontal canal canalolithiasis, the nystagmus is towards the same side, that is towards the ground. So this is called a geotropic nystagmus, seen in canalolithiasis, towards the right side. So this is called a geotropic nystagmus occurring in canalolithiasis. And the mechanism is because it's freely floating, it goes towards the ampulla and activates the canal. The other one, that is cupulolithiasis, as I said, this is adherent to the cupula. So when I turn this person's head to the right side, this autoconal debris is adherent to the cupula and it pulls the cupula down due to gravity. So once this cupula is pulled down, the movement is away from the ampulla. So there is inhibition of this canal. So subjectively, the other canal will be more active and we get eye movement to the opposite side. Means eye movement to the right side and the compensated nystagmus will be to the left side. So in a cupulolithiasis, when we turn to the right side, the nystagmus will be towards the left side, that is away from the ground. So this is called apogeotropic nystagmus. So I hope that is clear. So we'll have videos also. So in a geotropic nystagmus is due to canalolithiasis. It is because of the freely flowing debris which flows towards the ampulla. So head turn towards the affected side as shown in this picture will cause a strong nystagmus towards the ground. And a turn away from the side will cause movement to the opposite side and it will cause a weaker nystagmus. So just see this picture. This boy is made to lie down and now we are turning his head to the right side and see where the nystagmus is. It is beating towards the right side. So that is a geotropic nystagmus. Again, we should confirm by turning to the other side also. So see the intensity of the nystagmus here. Now he's made to lie straight. Next, he'll be moved to the left side. You see, again, it is beating towards the left side now, towards the ground, and it is much more intense when compared to the right side. In a geotropic nystagmus, the side where the nystagmus is more severe, that indicates the affected side. So here we can say that there is a canalolithiasis of the left horizontal semicircular canals. I hope that is clear. So the opposite is called apogeotropic nystagmus, and due to cupulolithiasis, as I said earlier, there is the cupula gets pulled downwards when the head is moved to that side, resulting in nystagmus to the opposite side. So when suppose I turn this head to the other side, just imagine it, the movement will be towards the ampulla, leading to activation of that canal. So that will cause an even stronger apogeotropic nystagmus. So in a geotropic nystagmus, the more severe part, the side where we get more severe nystagmus is the affected side. Whereas in apogeotropic nystagmus, the side which we have less severe nystagmus is the affected side. Again, I will show a video. So this patient is initially made to turn to the right side, and we see that the nystagmus is towards the left side. And again, we move towards the left side. When the patient is rolled to the left side, the direction of the nystagmus is towards the right side. Play that once again. So moving to the right side, the direction is towards the left side, and on rolling to the left side, the direction is towards the right side. So we see that the more severe nystagmus was when the patient was rolled to the right side. So in an apogeotropic, it means there is left posterior canal cupulolithiasis. I hope that is clear. Horizontal canal cupulolithiasis. So since that is complicated, I'll just show one more video. Just try to understand which side it is. In this lady, when we are turning to the left side, we see the fast component is towards the left side and see the intensity of the nystagmus. It's a geotropic nystagmus. When we are turning her to the right side, again, we are seeing the geotropic nystagmus. It is more severe. So the right horizontal canal canalolithiasis is what's happening there. I hope that was clear for everyone. And this guy, when we are turning to the left side, the nystagmus is towards the right side. Let's see. It's a very subtle nystagmus, apogeotropic, away from the side we are turning the head. It's an apogeotropic nystagmus to the right side. And when we are moving it away to the right side, we are having a nystagmus which is more pronounced than the other one. So this is the normal side. The initial one where we turned, that was the left side, that was the abnormal ear. So left horizontal canal cupulolithiasis. So treatment of horizontal canal BPPV is easy. It is a barbecue roll maneuver. So as shown in this picture, the head is kept supine and we use a pillow to raise it 30 degree. Then the head is turned 90 degree to the affected side. And we hold for 30 seconds. And we now look straight upwards for 30 seconds. And again, we look 90 degree to the opposite side. I'll show a video. And after that, we are making the patient lie prone with the hands in front of the patient, the face down. I'll show it's more evident in this video. So suppose a patient is having a right horizontal canal BPPV, we make the patient's head turn to the right side initially, keep for 30 seconds, then straight upwards for 30 seconds, then to the opposite side for around 30 seconds. Then we rotate the patient to that side so that the patient lies prone and the head is going downwards, and we keep in that position for 30 seconds. So this is the barbecue roll for horizontal canal BPPV. So after that, the patient is made to sit up. So this is easy to do. It's called the barbecue roll. Another method that is called the Guffoni's maneuver. Here, the patient is made to sit up, and then he is made to lie down on one side, and the head is turned either up or down. So there is a mnemonic to see which is which. It is GGG for geotropic. He is made to lie down on the good ear, and the head is faced towards the ground. For apogeotropic, he is made to lie on the affected ear, and the head is turned away. I'll show that with an example. Suppose so initial step is from the sitting position, he is made to lie down. And if it is a geotropic nystagmus, he is made to lie on the good ear. If it's apogeotropic, he is made to lie on the affected ear. The next step is turning the head 45 degree upwards or downwards. So if you remember that code GGG, for a geotropic, the head is turned 45 degree downwards towards the ground. For apogeotropic, it is away from the ground, 45 degree away from the ground. So after doing that, the patient is made to sit up. You'll see this example. So if it is a right apogeotropic means the patient is made to go into the right side. I'll just show that video once more. For right apogeotropic, AAA, so rise on the affected here, the head is tilted away from the ground, maintain for 30 to 45 seconds, and after that, make the patient sit up. So this is how we do the Guffoni's maneuver. So it differs based on whether it is a geotropic or an apogeotropic nystagmus. So what to do after we do this horizontal canal repositioning techniques? We should repeat.
So if your assistant is wrong, if you do the wrong method,
Thing is what?
what is that?
So it's a known issue where we do, suppose we do this maneuver for an apogeotropic, it can even become geotropic as a result of the maneuver. So we have to do the geotropic maneuver later on. So it has been described. Even if we change it and become something else, we can just do the maneuver for that. It's okay. Yeah. So even if it occurs as a complication, we can just do the maneuver for that nystagmus. So what to do after the supine roll test? After this Guffoni or barbecue roll, we have to repeat the supine roll test and see if it has been cured. If cured, we can send the patient home, and we achieve cure in more than 90% after the barbecue roll. And if it becomes a geotropic nystagmus after the maneuver, again, we just have to do the maneuver for geotropic nystagmus. So finally, a word about anterior canal BPPV. It is the most rarest form of BPPV. Again, the symptoms are stimulated in vertical movements. And usually the thing is, as we said in posterior canal BPPV, it is an upbeating nystagmus with torsional component towards the affected side. Here it is a vertical downbeating nystagmus with a torsional component. And the thing is, it is often positive bilaterally. So for horizontal and posterior canal, we were trying to localize which side it is. For anterior canal, actually, it is not needed to localize which side it is because the treatment is common for both sides. So we just have to diagnose anterior canal BPPV. So I'll just show an example. So we're doing Rixolpike in this lady. We're turning the head 45 degree, then making the patient lie down. What they are expecting is a downbeating nystagmus after latency. So if you get a downbeating nystagmus, as it is clearly seen here, it is suggestive of an anterior canal BPPV. So the treatment for anterior canal BPPV is the head hanging maneuver. And as I said earlier, the side is not important because the treatment is the same for both sides. So treatment is also very easy. We just make the patient sit upright. Then the patient is made to go downwards, lay supine with head 30 degree going backwards. and we see if there is reproduction of these symptoms. And after the symptoms have subsided, we make the patient go to a chin to chest position and maintain it in another 30 seconds. After that, we make the patient sit up. So as I said, it's not necessary to identify the site, as the same maneuver is used for both ears, and it is very easy to do. You just see in this video. Make the patient lie down 30-degree downwards, hold for 30 seconds to 1 minute. Then chin to the chest position for another 30 seconds. Following which the patient is made to sit up. So this is the head hanging maneuver for anterior canal BPPV. So this is in broad the 3 different types of BPPV, how to diagnose it and how to treat it. And just about
why does it get more open to posterior?
there are some costly mechanisms is because the posterior canal is more anatomically susceptible for the otoconate to dislodge into. And one more theory is that most people lie on the right side. Again, it makes it anatomically predisposed to go into the horizontal posterior canals.
Right.
Yes. So what are the further management?
What they lie on left?
Right makes it more susceptible. And always the posterior canals are more anatomically susceptible to hold this dislodged otoconate. There are articles showing that.
If it's not lying down on left, then they're protection.
Lying on the right increases in risk. Lying on the left, right. Left, whether it protects, I'm not sure. Makes it more susceptible for the otoconate to dislodge into the posterior canal. There are articles showing that.
It's not happening.
I'm not sure. I have to check. So, what are the further management strategies in BPPV? There are some.
You suggest everybody should lie down.
So coming to the further management strategies, there are some home-based maneuvers which they can do if they are not having adequate cure in the hospital-based setting. And we'll see the role of pharmacotherapy and vestibular rehabilitation also, and what to do in refractory cases. So these self maneuvers can be done at home. They involve the brand of exercise, the modified Epley maneuver, and the modified Simmons maneuver. So the brand thereof means it is something similar to a Simmons. Again, the side does not matter, which we are doing to both sides. So first, the patient is made to turn the head 45 degrees to the left side, then lie on the opposite side, followed by coming back to the neutral position. Again, turn the head to the right side and then lie on the left side. So these exercises can be done in repetitions. Like there's a schedule that most people suggest, 5 repetitions over 10 minutes, morning, noon, and evening. So patients with this is for posterior canal BPPV, and it can be done at home. What about the role of pharmacotherapy? Even though we routinely give all of beta histone and all, it is not the primary treatment, and most studies have shown that it is much less effective in controlling the symptoms and the repositioning maneuvers. And also, some people also say it is not ideal to give it because it causes vestibular suppression and it interferes with the adaptation process. However, we can definitely give drugs when there is severe symptoms such as severe nausea or vomiting. And where there is disabling vertigo, it does not respond. We can always try drugs. And the most commonly used one is beta histine. So it's histaminergic agent. And this is one we usually use. The dose is actually recommended for many years as 24 to 48 mg per day in divided doses. So, and there are some studies which show that combining those two can have significant reduction in the BPPV symptoms. And what the role of vestibular rehabilitation, this was.
How long we need to give beta histone?
It is not actually recommended in BPPV. So based on case to case basis, maybe a few days is more than sufficient. 3 days. if there are significant symptoms, if this not responding to our repositioning maneuvers for benefit of the patient for symptom control, we can give, but not for prolonged usage because it is said to interfere with the adaptation process of.
So you mean to say that a hybrid treatment and the patient is coming with a good symptom, is a big manual
Yes.
and not harm of them.
No. And if the treatment is successful, we don't have to give beta steroids. So vestibular rehabilitation was publicized a lot previously, but current evidence show that it is not superior to enough our repositioning techniques. However, both can be combined to reduce the chances of relapse. So maybe exercises like tandem walking, one leg balance, all have been tried for this. And what to do in a refractory BPPV? There are surgical options, but it is very, very rarely done, less than 1% of the cases. So the options which can be done are surgical occlusion of the posterior canal using some bony plugs. But the side effect is definitely thing is we are making the posterior canal non-functional, and there can be post-op hearing loss and dizziness and all. Other options which are again not routinely done is the posterior ambulatory nerve resection. Then newer things which have been tried are intratympanic dexamethasone and argon laser for ossification of the posterior canal. These are all being tried on a case-to-case basis only, not actually approved. They are the emerging options. And what is multi-canal BPPV? It is usually seen in the setting of trauma. Again, diagnosing it is very difficult because the nystagmus may not be the typical classical one we describe in one of these canals. So the treatment liberatory maneuvers are also complicated and failure risk is high. Failure rates are high and recurrence is also high. And in pediatric BPPV, again, we can do the same techniques. There is no contraindications again, but the data is limited. So we'll end with just 2-3 rare reports. This is something called sitting up vertigo, where this was a case report back published in 2023, where a gentleman was evaluated for vertigo. Initial X-Holpike was negative, but the patient was given set to do multiple sit-ups. And on the next day, after repeating the Dix-Holpike test, there they showed an upbeating left torsional nystagmus, which was very consistent with the diagnosis of a posterior canal BPPV. So there's a postulated mechanism for this, because initially what they told was there was a large otoconal debris which was causing a partial canal jam in the periambulary region. All these repeated sit-ups due to this stress caused disruption, means a disintegration of this otoconal debris, and it made into many smaller particles. And these particles the next day while doing Dix-Holpike activated the canal, leading to our typical nystagmus. So this is one few rare reports. Another complication that can occur as a result of this canal repositioning techniques is canal jam. So where this otoconal debris can get jammed in one of the canals. So once the this canal gets jammed, there is a persistent deviation of the cupula, and then we can get a non-fatigable persistent nystagmus. Usually what we say is peripheral nystagmus is fatigable, but if it persists and not fatigable, we can think of something like a canal jam. And overall, the prognosis of BPPV is great. About 1/3 of the patients have remission if they are treated properly, and less than 1% ever need surgery. So as a last slide, this is a complication of long-standing vertigo dizziness called PPPD, persistent postural perception dizziness. So something like we see in our clinical setting where patients keep complaining of vertigo, even though we have nothing on clinical examination or imaging. So initially they might have had some insults like a BPPV, but now even on testing or anything, we're not getting anything. So it is said to be associated with migraine, anxiety, and depression, and treatment is with antidepressants rather than our anti-vertigo treatments. So
especially in the it comes to the persistent feeling of like that is a different. So yes, in the bench like that, you can just in the factor be here. So you do it. If after we should not go back and do it immediately after this year, see the your it's not successful. Wait a minute. Again, has to be very clear. Which comes on a weekend was better. Then you happen to come after 2 weeks. Evidently, especially when you have a person speaking, that is the kind of makes it possible. That will be so. Here you may see patients with a BPPV, we are not doing it because they are hardly seeing patients. Like even last week, there are patients where we actually came to the relax.
That's all. Thank you.
Right, consider it small. That is person. So more patients who come up with it. And I'm not sure whether it's the position. You are not getting it pre-position with it. You don't see anything. Then consider.
That's all.
Most often you it is 95%. All chances that we can positive. So do every on. Rarely get that and it is then some people who face like this. Come in then I do that. I get that one. That's a very fair. Hard one hand. The small dollars of question. To do a posting, I think based on that, you don't get anything which comes at the second or day. And it's that different. Or not getting anything. The most commonly mistaken answer is to them. You know what they go to that second. And it's still
Vestibular paralysis.
More than paroxysmal because it's twins. They come and take the time about they go every day for the last 2 years, for last 2 months. It is unlikely to be BPPV. People will not get BPPV daily. BPPV once happens, then they are another 2-3 months or 6 months, 1 year. If they come very frequently, almost like a time, whenever I get up in the morning, I have work. That is not BPPV. Then you ask for the history for a headache, a headache, those are all there you can give prolonged with family medicine. That's a long-term device.
Ending the session.